merdeka, umatnya bergerak berganding bahu. Yusing menyahut harapan bangsa menjadi universiti termaju. Dan masa keras kegiatan penyelidikannya untuk dunia, terus progresif membina insan, berdisiplin mengamal nilai mulia. Benteng harapan untuk terus maju.
للذين آمنوا ربنا إنك رؤوف رحيم اللهم أحسن عاقبتنا في الأمور كلها واجعل حياتنا حياة طيبة آمنة مطمئنة برحمتك يا أرحم الراحمين. Ya Allah, ya Tuhan kami yang Maha Pemurah lagi Maha Penyayang, sesungguhnya hanya kepadamu kami merafakkan setinggi-tinggi kesyukuran. Pada hari ini kami berhimpun di majlis yang mulia dan bersejarah ini, memohon rahmat dan hidayah dari sisimu ya Allah. Semoga dengan rahmat itu Engkau kurniakanlah hidayah dan petunjuk, dan satukan pemikiran kami. Engkau perkukuhkanlah perpaduan, Engkau hindarilah fitnah dan pertelingkahan di kalangan kami, dan Engkau perbaikilah urusan agama dan dunia kami. Allahumma ya akramal akramin. Kami memohon agar pertemuan ini dianugerahkan hidayah dan taufik, agar urusan harian kami berjalan dengan lancar, memperolehi kejayaan dan keberkatan. Jadikanlah sentiasa mendapat petunjuk ke jalan yang diredai olehmu ya Allah, dan hindarkanlah hati kami dari sifat-sifat mazmumah yang boleh menyekat keharmonian dan perpaduan. Selamatkanlah kami daripada perselisihan yang membawa kepada perpecahan dan binasaan. Allahumma ya zal jalali wal ikram. Tiadalah sesuatu urusan itu mudah melainkan Engkau jadikannya mudah ya Allah. Terangilah hati kami dengan cahaya petunjuk-Mu sebagaimana Kamu menerangi bumi ini dengan matahari-Mu. Kurniakanlah kepada kami kesihatan anggota, kecerdasan minda, ketenangan dan kekuatan untuk kami menepani segala cabaran ya Allah, dan mengangkat martabat diri sekeluarga, masyarakat dan negara. Rabbana atina fid dunya hasanah wa fil akhirati hasanatan wa qina azabannar. Sayyidina Muhammadin wa ala alihi wa sahbihi wa sallam. Walhamdulillahi rabbil alamin.
Di majlis pada pagi ini. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin, wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi washabihi ajmain. Dengan nama Allah yang Maha Pengasih lagi Maha Penyayang, selawat dan salam kita panjangkan kepada junjungan baginda Rasulullah SAW. Allahumma salli ala sayyidina Muhammad wa ala ali sayyidina Maulana Muhammad. Chairman of UC Board of Directors yang berbahagia Dato Siddiq Fadil, Deputy Vice Chancellor Student Affairs and Alumni yang berbahagia Profesor Madya Dr. Muhammad Rosdan Muhammad Jalani, Registrar yang berbahagia Datuk Muhammad Hazwan Rozali, The Dean of Medicine and Health Science yang berbahagia Prof. Dr. Muhammad Samsi bin Muhammad Aris, dan saya ingin mengalu-alukan juga Tan Sri Profesor Syekh Hafsah yang dapat datang pada pagi ini. Beliau ni actually banyak mendidik saya di UKM dulu semasa beliau selaku Net Chancellor di UKM. Saya dekan masa itu, dan in fact bila saya ke USIM ni pun beliau banyak membantu dengan program Mati Insan. Terima kasih Tan Sri, thank you, for your presence this morning. Seterusnya, members of UC Board of Directors, University Management Committees, Senate Deans, Professors, Tan Sri, Dato, Honorable Guests, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera dan salam integrasi ilmu nakli dan akli. So Alhamdulillah, today the Fakulti of Medicine and Allied Health, FPSK, UC Sains Islam Malaysia, or in short USIM, is able to organize the inaugural professional lecture by Yang Berbahagia Profesor Dato Dr. Mahmud Noor. Okay, so ladies and gentlemen, before we start, can we give a big round of applause, as a motivation to Dato Mahmud. So I would like to congratulate the organizing committee, okay, to organize this event this morning. So on behalf of USIM, I welcome all of you to this lecture by Yang Berbahagia Professor Dato Mahmud Noor. So I understand that members of the professionals, bodies, regulators, industries, practitioners, academicians, Sharia scholars, postgraduate and undergraduate students are here today to listen to you, Dato, insyaAllah. And it's important to give you a full support this morning. So thank you for spending your valuable time with us today. Dan selamat datang to USIM, especially for those who come to USIM for the first time. So ladies and gentlemen, Yang Berbahagia Professor Dato Dr. Mahmud professorial talk is entitled Challenges and Achievements in Developing Pediatric Surgery in a Developing Healthcare Service in Malaysia. So no doubt, children are the inheritors of tomorrow. We all know that. So their welfare, including their health and well-being, should be adequately addressed today to ensure their future is not burdened by disabilities and diseases, otherwise can be prevented. So as many infectious diseases and childhood diseases have been the major focus for the past decades, congenital malformations and malignancy has become more important and still contribute to the cause of infant mortality. So there is also a rising trend in pediatrics, non-incidental injuries and road trauma. So it is therefore imperative to have more pediatric specialists. Sound like somebody who expert in medicine giving a talk this morning. So ladies and gentlemen, so as Malaysia is approaching the status of developed nations, so a more comprehensive healthcare is needed. So hence, being one of the important specialties, higher priority should be considered to the development of specific specialties in care of children. And we know that in recent years, communicable and infectious diseases is well under control due to a good preventive and public health approaches. So however, perinatal mortality remains a problem in our country, and with infant mortality ratio of 1 to 1,000 births. So more collaborative effort therefore is needed to encourage a close partnership between pediatric surgeons and neonatologists. So this will improve the management of complicated cases and salvage premature and low birth weight babies, especially those born with treatable congenital conditions. So special consideration should also be given to improving childhood malignancies, which has been in an increasing trend due to the current pollution and hostile environments. So perhaps a special children's hospital could prove to be beneficial in this modern era in aspiring Malaysia to be a developed country. So today's lecture will also discuss, the current challenges in improving pediatric surgery as a specialty and also recognizing the success that has been achieved throughout the years. Therefore, I'll take this opportunity once again to congratulate Professor Dr. Mahmud for choosing this interesting topic to be presented this morning, which is very timely, especially with the increase in health awareness among Malaysians. So being the pioneer in this challenging specialty, he has more than 35 years of teaching and research experience in this area. That's really, significant contribution to the countries, 35 years, in these areas. So I would like to take this opportunity once again to thank the organizing committee of FPSK for making this lecture a success. So thanks to all for attending this lecture, and I hope everyone will gain some knowledge from today's lecture, inshallah. So may our charitable deeds and effort for the Ummah get their blessing from Allah subhanahu wa ta'ala. Amin. Assalamualaikum warahmatullahi ta'ala wa barakatuh.
Thank you, Dr. MC. It's my utmost pleasure to show you this short introductory video on Yang Berbahagia Professor Dato Dr. Mahmud Noor. Please enjoy.
born on the 21st of September 1945. He had his early education at the Malay College in Kuala Kangsar from 1955 to 1965. He graduated in 1970 as the second batch of medical students from University Malaya. After passing the primary fellowship examination of the Royal Australasian College of Surgeons, he proceeded to Edinburgh, where he obtained the fellowship of the Royal College of Surgeons in 1975. He received initial training in general and pediatric surgery at the University Hospital in Kuala Lumpur and in pediatric surgery at the Hospital for Sick Children, Great Ormond Street in London, and the Royal Children's Hospital in Melbourne. In 1976, he was entrusted with the responsibility to establish the academic department of surgery at the Faculty of Medicine of University Kebangsaan Malaysia, and to head the surgical service in one of the general surgical units of Kuala Lumpur General Hospital. He was responsible for providing and developing the pediatric surgical service within the Department of General Surgery at HKL in 1976. He later became the Professor of Surgery and Dean of the UKM Medical Faculty from 1984 to 1990. In 1990, he left the university to rejoin the Ministry of Health, where he headed the newly created Department of Paediatric Surgery at the Institute of Paediatrics. He was appointed as rotating head of the Institute on several occasions. Amongst his many professional achievements are the first Malaysian to lead a team to successfully separate a pair of conjoined twins in July 1988. He has been involved in the separation of 10 pairs with 15 survivors. He established and headed the first comprehensive burn care service in the country at Hospital Kuala Lumpur in September 1988. He was invited by the College of Surgeons Malaysia to be the Academy of Medicine Ismail Orator in 2012. He is the founding and current president of the Child Friendly Healthcare Association of Malaysia. He was also the founding president of the Malaysian Association of Paediatric Surgery in 2002. He is currently the Professor of Surgery, member of University Senate, and member of numerous faculty committees in USING. He was conferred Dato Paduka Chura Si Manjakini by the Sultan of Perak. Kesatria Mangkunegara Pingat Pekerti Terpilih, Honorary Doctorate of Medical Science, UKM. He is also a Fellow Royal College of Surgeons, Glasgow, Scotland.
I'm sure that you all agree that's very impressive CV. So without further ado, I would like to invite Yang Berbahagia, Professor Dato Dr. Mahmud Mohd to the stage to deliver his Syarahan Perdana titled Challenges and Achievements in Developing Pediatric Surgery in the Developing Healthcare Service of Malaysia. Please welcome Dr.
Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. Assalatu wassalam Sayyidina Muhammad ala asyrafil anbiya wa ala alihi wa sahbihi wa sallam. Bit of a sore throat. Assalamualaikum warahmatullahi wabarakatuh. Saya ucapkan terima kasih kehadiran kepada tamu utama, Chairman of the University Sains Malaysia Board of Directors, Yang Berbahagia Dato Siddiq Fazil, Yang berbahagia Vice Chancellor, yang berbahagia Profesor Dato Dr. Musa Ahmad, Deputy Vice Chancellor Profesor Madia Dr. Madrush dan Majalani, yang berbahagia the pendaftar, the registrar, yang berbahagia Dato Muhammad Aizwan Rosali, the Dean of Medicine and Health Science, yang berbahagia Professor Dr. Mashamsir bin Muhammad Aris, members of the University's Board of Directors, University Management Committees, the Senate, the Deans, Professors, Dansri, and honorable guests, ladies and gentlemen. I'm delighted to be present here this morning to deliver a lecture in front of such a distinguished guest. I'm very happy with the presence of my family, on both sides of the family. And on my side is I'm represented by my brother Colonel Ahmad Nazri and his family, the so-called Keturunan Tokobat. And on my side is Tan Sri Said Abdul Jabbar. From the Keturunan is Dato Said Hassan Shahabuddin, one from Perak, one from Kedah. Ladies and gentlemen, this lecture is about my journey as in pediatric surgery, which is a new specialty in Malaysia. It covers a period of more than 35 years, beginning with my secondment to University of Kebangsaan Malaysia in 1972 as a trainee lecturer. My qualification as a fellow of the Royal College of Surgeons in 1975 and training at the Royal Children's Hospital in Great Ormond Street in London, also very well known as GOSH, G-O-S-H. And I was the founding head of the Department of Surgery in 1976 and advanced training at the Royal Children's Hospital on Flemington Road in Melbourne. And I returned to the Ministry of Health in 1990 with some sadness, but I would like to say this is off the script actually. I was undecided whether to stay on in UKM or whether to leave in UKM and join back in my parent body, this Kementerian Kesihatan. I tell you this anecdote, which only is known so far between me and my wife, that I was at the end of the opening ceremony of the meeting of the Academy of Medicine. I was representing the Malaysian Association of Pediatric Surgeons, and I introduced myself to His Majesty Sultan Azlan Shah, and because he was a student of my father, and when I introduced who I am, he said, "How? You had a very stylish father." And then I said, and who's beside you? He said, "Well, that's my wife, Sharifa Hafsa." And I asked her, "What are you doing?" "I'm with my husband, he's my boss." She's looked up there. No, that cannot be. One of you must leave." So it was not a difficult decision for me to leave UKM and join the Ministry of Health. It's such that fate is such that you fulfill the destiny. One door is closed for me in UKM, but a bigger door opened for me in the Ministry of Health, where when I returned at the Ministry of Health, Tan Sri Abu Bakar immediately gazetted me as a pediatric surgeon, established the Department of Pediatric Surgery, and I was taking charge of the Institute of Pediatrics. And from then on, my figures at the super scale rose up quite rapidly from B, D, C, B, and A. Right? So, and in that position, I was able to do quite a lot in the development of pediatric surgery. If I stayed on in a university, I probably ended up as a vice chancellor. Anyway, that's the best thing I could go. All right. Now I'll like to give it an outline of the lecture because time is the limiting factor here. Can I have the next slide, please? I'd like to cover 5 major areas. I'd like to start with the definition and scope of pediatric surgery and the challenges in the care of sick children. Some historical perspective in the development from the time it first started at the University of Malaya Medical Center to a department at the Hospital Kuala Lumpur, and the important role of University Kebangsaan and Malaysia in developing the discipline in HKL, followed by the role of Paediatric Institute, and I also will highlight the further advancements made by UKM when it moved to Cheras. I will then reflect on some of the personal achievements in my practice of pediatric surgery and end with some ideas of how we go forward. Next slide. Now, let me begin by stating that pediatric surgery covers surgery on children until the age of 18. The cases range from obvious abnormalities in children detected at birth or later in life due to malformations and tumors. Older children may present with injuries due to accidents at home or on the roads, and burns which are usually happening at home. Now this slide shows an esophagus that is not joined to the lower part and the stomach. The lower end is usually connected to the trachea or windpipe and is called tracheoesophageal fistula. And if not detected early, saliva will be aspirated into the lungs to cause pneumonia. In the old days, the babies will die of choking of the saliva and lung infection. Next. Going lower down, there are intestinal defects, where a portion is not connected to the rest of the intestines. On the right is Hirschsprung's disease, where some cells responsible for movement are missing, resulting in obstruction and distension of the bowel above it. Next is going to the bottom. You can find cases where the anus is absent, causing obstruction to the bowel. Next. Or there's another common problem where the abdominal wall is absent or not well formed, and the stomach and intestine are found outside the body. In the first picture in these patients, the bowel is protected by suturing a bag of silastic material around it as an initial form of treatment. And on the right, even the bladder and part of the large intestines have protruded out. Next. Now, some babies can be born with huge tumors, sometimes bigger than their head, and some huge intra-abdominal tumors. Or they can be born joined together or conjoined twins, which are very rare. Many, like the one on the left, are not compatible with life because they share a heart. With the new imaging technology, we can actually detect them very early in the uterus, in the early first trimester, and advise termination of pregnancy, rather than allowing the mother to proceed and have a cesarean section for babies who are going to die. But there are also cases where the possibility of successful separation is very high, such as the twins seen on the right, but I'll talk to them about them later. Now, there are certain requirements in pediatric surgery. So the cases presenting to the pediatric surgeon can be very widely. In treating them, we have to bear in mind several factors. Children are not small adults, okay? Especially the newborns. We have to bear several things, matters in mind, that even within the age group of under 18 years of age, there are differences in the anatomy and physiology. Emotionally, they are also very different. They vary a lot. So the treatment regime must vary according to their age. Ideally, they should be treated in a hospital dedicated for children up to 18 years of age. The hospital should have comprehensive services from all specialties of medicine and surgery. They must be handled by surgeons and other specialists who have been trained in the care of children. The hospital must also have comprehensive diagnostic and imaging facilities catered specially for children, as well as rehabilitation services with physiotherapists, occupational therapists, play therapists who are trained to cater for the needs of children. In other words, the hospital has to be child and family friendly. The challenges in meeting the requirements of the care of children, as I faced initially in hospital Kuala Lumpur, is that this is a big challenge in Malaysia. Although we have wards for children, the whole hospital system is geared towards the care of adults. So there is competition for financial allocation, operating time, or competing for the emergency list, the ICU beds and intensive care, for the anesthetists who may not even be trained in pediatric anesthesia, and also clinic space that are appropriate for children. Another constraint is that pediatric surgery was not recognized as a specialty, and we also have inadequate number of trained nursing staff and other support staff, especially in the surgical care of the newborn. Next. Now, what will be the impact of not meeting these requirements? So when the children were seen in hospitals which do not meet the standard requirements, the impact can be quite adverse. There is considerable delay in the diagnosis. They may be referred late, already with complications. They are poorly transported, especially the newborn, are in a poor state on arrival, with low body temperature called hypothermia, and dry called dehydration. And they are put in a crowded ward where they're prone to cross-infection. Now, all these factors will lead to increased mortality. I will start with a bit of acknowledging the pioneers in the early development of pediatric surgery. There were a few pioneers who began to address the problems of caring for children who need surgery. In the late 60s, Professor K. Sundram, an expatriate, played a very important role. He was the first trained pediatric surgeon then. Began to practice in the University of Malaya Medical Center, and he did as any other surgeon together with general surgery in adults. He was my teacher and mentor in pediatric surgery, and he was the one who was responsible for sending me to Great Ormond Street where he was trained. He was also the first to separate the first conjoined twin in the country at University Hospital. Then we have Dr. Karpal Singh, who started pediatric surgical services in hospital Kuala Lumpur in the early 70s. He obtained the fellowship at the Royal Australian College of Surgeons in pediatric surgery in 1972. But he left in 1976. And when he left, pediatric surgery of HKL was transferred to the UKM surgical unit. Next. I would like to take this opportunity to go into the role of UKM from the historical perspective. Before I describe the important role of UKM in developing pediatric surgery in the country, let me start with a bit of its history. As you know, the UKM Medical School was established in 1972 with Dato Amir Abbas, who's present here. I'm very honored with your presence, Dato, who has honored me with your presence today. As a founding dean, he recruited many young doctors, especially from the Ministry of Health, to be trained and subsequently became pioneers in every specialty required for the medical school. I'm grateful to be one of them, who later became the founding head of the Department of Surgery. At that time, my medical officers, I think once present here, Dr. Yusha Wahab and Dr. Zulkifli Aidid is not here. And later I was joined by, who's now Emeritus Professor Frida Mia. She was a medical officer actually at the time, but a bit late, but then she became a surgeon and then she joined us in UKM. Only Dr. Zulkifli Aidid became a pediatric surgeon. With regards to the development of the surgical department, there are a few names that I wish to mention. Firstly is Professor John Masterton, a prominent burns expert from Monash University, Emeritus Professor Boris Ewing from University of Melbourne, and Emeritus Professor Sir Harry, and Amantado from the University of West Indies, who were recruited and funded by the Commonwealth Fund for Technical Cooperation. Without them, it would have been difficult for me to carry out the task of developing the surgical services as well as academic program. I would like to take a little bit of time to tell about Professor John Masterton, a little story. On his first day at work, and it was the day that my team on call, we had the Japanese airline crash at Subang. The survivors were sent to UM or HKL. We were at the time totally unprepared for mass disaster. Due to inadequate facility in the hospital, especially for burn care, most of the major burns did not survive. But most important thing, I learned a lot about management of burn injury from him. Next. The facilities in UKM Surgical Unit for Pediatric patients was upgraded when it was declared as a teaching hospital in 1976. So we took to improve the facilities by buying a few equipments. And at that time, we were fortunate to obtain a loan from Saudi Arabia government to purchase all the equipment for the faculty as well for the needs of the teaching, even in the hospital. We improved the ward, not only the ward facilities, but the operating theatre and intensive care. And we also sent people training in neonatology and pediatric anesthesia. And we managed to reduce the mortality, especially in neonates. This is the picture, as you can see, still far from ideal, despite our contribution in purchase of instruments. Next. In 1990, as I stated, I ended my DChip at UKM and returned to the Ministry of Health. And I'm very grateful to Tan Sri Abu Bakar Sulaiman, who's unfortunately could not be present today this morning, for that he immediately gazetted me as the first pediatric surgeon in the Ministry of Health to head the newly formed Department of Pediatric Surgery. In 1991, we moved to the Institute of Pediatrics. Since UKM did not have a separate Department of Pediatric Surgery, all of the pediatric surgeons from UKM served at the Institute of Pediatrics until they moved to Churas in 1997. The facilities of the Pediatric Institute were much better in terms of having its own operating theatres, intensive care. However, there were serious issues such as no emergency services, only basic radiological services. I think Dr. Zaliha, who was pediatric radiologist, is here. She will testify to it. And cases were confined mainly to general surgery, because there wasn't enough space, orthopedics, and general pediatrics with neonatology. But we also, for the first time, have a proper burns unit for the pediatric patient. Now, in 1994, as Chief of Surgery in the Ministry of Health as well as Head of General Surgery in Kuala Lumpur, I requested for an audit to be done to burns in the orthopedic ward. They were taking care of orthopedic ward as well as in the Pediatric Institute. The outcome of the study showed no mortality under 1 year and only 2 deaths between 2 and 12 in the Pediatric Institute. That is about 3 to 4 years after the births was taken care of by pediatric surgeons in the institute. On the other hand, the mortality was very much higher in children between the ages of 12 to 18 were treated in the orthopedic wards. As a result, I recommended that a new burns ward be built in HKL. I was able to obtain the necessary funding, and it was about 4 million, and even took part in designing it. It was complete in a sense with its own resuscitation area, burn bath, a special electrical hoist to lift patients, a separate operating theatre, intensive care beds, and I remember each of the bed was the cost of a Volvo. Isolation rooms with ventilatory support, separate ward for recovery and rehabilitation, and we sent a core team to Sydney for training to both the adult hospital as well as children's hospital at Westmead. We were fortunate to get the money to build this birds unit because the justification was we were preparing for the Commonwealth Games. So that's much easier to get. Now, I would like to talk about further development that's taken place in pediatric surgery at the UKM. In 1997, the medical faculty moved to the new hospital in Cheras. In fact, before I left the faculty in 1990, there were already talks about having a new hospital in somewhere, and I could remember this very well because I was a member of the university equivalent of LPU, there's the council, and in the meeting was chaired by the Vice Chancellor, Tan Sri Hamid, and the member was Tan Sri Abubakar himself, and the KSU was Dato Latif Sahan, I think his daughter is here, Professor Zarina, and we decided that in the best interest of UKM, we should have a hospital, and that was realized in 1990, after, I can't remember the date, but UKM was built. Now, there were no separate pediatric surgical department when they moved there. However, pediatric surgeons still managed to develop niche areas such as advanced pediatric minimally invasive surgery, or MIS. So that's a picture of MIS. You don't have to have a big cut in the abdomen. Sometimes called keyhole surgery in newborns and children. And the record is in a 2-week old baby who had almost the whole of a pancreas removed laparoscopically. This is a world record. And this picture actually shows Professor Diane, who's here, who is one of the top laparoscopic surgeons in the world, I guess. She has even, yes, the keyhole in the pancreatic, in the, I think in the 6 weeks, and I think that even the 2 weeks neonate. I'm still the adjunct professor at UKM. Never left it. Now, we also needed a facility for advanced surgical skill training, and grateful to the Vice Chancellor who managed to get some fund to build this very well-known ASSC, or Advanced Advanced Surgical Skills Center, I think one of the first in the region. And next, we also managed to get funding to have a new hospital, which I think we're going to be very proud of. But it's about to be ready. It'll be functioning soon. Okay. And this is actually a stand-alone children's hospital, whereas the one that's been built in the Ministry of Health old hospital ground is called a Women and Children's Hospital. But I do not know how much intermingling are there between the facilities of the two hospitals. I have no idea. Now, what are our achievements? Now I'd like to talk about achievements, right? I wish to reflect on what I've achieved in pediatric surgery. First, let me highlight the type of cases I've operated. Now, we have not had any success for the treatment of TOF for many years. From 1970, we had no success until 1979, after the UKM took the Paediatric Surgical Service. And with the first early survivors on the left side, and on my right is a picture of Faiz, and he's here this morning with his mother, Puan Farida. I don't mind you picking up your picture. You have not changed much, and Faiz has not changed much because Dr. Poo, who was responsible to take care of him, noticed him and said, "You have not changed, Faiz. You're the same." That's why he said that there. Now, and actually, Faiz is very fortunate in the sense I just came back from Australia, and I was working under, Ned Myers, who was, a thoracic surgeon. He's got the biggest series in esophageal atresia with the same condition of 5 years. Okay, this is a very rare type of esophageal atresia without a fistula. It is one of the most difficult type to repair due to the wide gap between the upper pouch and the lower pouch. So, and he was too small to be operated on. So we put a tube through his stomach so that his saliva, will not be continuously, collecting in the upper pouch, and we had to suck using a machine for about 3 months, and Mom was very good ensuring that the machine was working. In the process, we burned 3 Gomco machines, which is quite expensive at that time, before we could operate. Now, at the operation, which we had to do, it looks, the esophagus that I put out the esophagus is put out, but it's not his esophagus. It's tiny, very tiny, all right? And the sutures that we had to put in are very tiny, slightly bigger than your hair. So we need to use some kind of magnification. So we couldn't put the thing together. So what we did was introduce a new technique, Perubatan, called the Levantitis procedure, where we cut circumferentially the muscle which is thick in the upper pouch, and we can get a bit of length. And sometimes we can do a double myotomy, like this one. At that time, we were not that very clever, so we tried to do it in the chest. It was very difficult. But once we bring it out into the outside, it's much easier to do. So this is a procedure. So you can see, you can lengthen the esophagus, and lo and behold, we could join it. But of course, with a price. He had a lot of reflux, and then he had a lot of chest infection, which was taken care of, Professor Damien, and I'm very grateful for your dedication. People say that Bu Damien, it's impossible for babies to die in the hand. Okay. Now I'll talk a bit this system highlights actually conjoined twins. Next. Now the surgical separation of the first conjoined twins took place on 17th of July 1988. They were joined the lower chest and the abdomen, and they shared a liver, and we came under the media glare when the whole nation was excited. I was very nervous, and it took me about 13 hours to separate the twins. Unfortunately, we were unable to trace them to here. Now, separation of conjoined twins requires a lot of preparation and teamwork, and has to be well planned, and you have to ensure that how do you deal with blood loss, because separating the liver in a newborn child is like cutting through tofu, all right? And the bleeding was horrendous, actually. So next slide. That was the media booing me in Sunday Times. Okay. Now the first twin, we also had problem with closing up the abdomen because of the huge defect, but we managed to put a patch using human Duramagitor, which is lyophilized, and put the patch on, and then we could bring up the skin quite under tension. But I didn't want to show the photograph. The scar is not good, actually. It's quite very, not very professional looking. So the next case, we are much better. And I'll go. The next one. Yes, this is from Klaten. By the time we operated on this set of twins, they were also joined at the lower chest and the abdomen. We were more experienced. We also had the advantage of having the newer electronic dissector, which makes it much easier to cut the liver, because it can destroy the liver cells, but not cutting the ducts and the vessels. So it's also so much easier to do. And we took a shorter period of time. There was less bleeding, and we also tried the new approach, courtesy of Mr. Isa Umar, who is a plastic surgeon. He said, "Wait, you guys, you don't know how to treat wounds." This is the usual talk of a plastic surgeon. They tell you don't know how to treat wounds. So he said, "Your problem is the tension here. release the tension here so that you can put, and then we take a graph, we put at the top here. So this is what happened. You can see nice skin, and then a little bit of a scar is under the armpit that's not seen. So I thank Mr. Wisoma, I just couldn't get him to be here this morning. He's a character. Okay. For those who know, everybody laughed when I mentioned Wisoma. Okay. Now next I'll go to the treatment of the next one. Now this is the other time when they join at the perineum. This is called the ischiopagus. The separation here is no nightmare for the anesthetists because on both ends, as you see, it was a nightmare for them when the face was together and they do it quickly. Pop, 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 you know, got the very good ones, okay? Because the moment you paralyze one side, the other side is also paralyzed, okay? So you have to do both. Okay? This one, no big deal. But the problem is in the reconstruction, right? The reconstruction, because they share an anus, we have to create an anus, and also, you know, make sure that, you know, the penis are in the right place. Okay. That could be a problem. Say. Next one. Now this is the 10th conjoined twins. You know, they came with intestinal obstruction outside, so we had one of our pediatric surgeons who did a colostomy, and they were sent to us. And then the separation was, the only problem was getting the two pelvis together. We need to cut the bones, the orthopedic surgeon has come, and then reconstruction of the anus and the vagina. Next one. Next one. Yeah. Now, we did an analysis of our performance from 1970 upwards. Okay. In terms of mortality, my greatest achievement is the decrease in the total mortality as shown in this slide. Somehow, Mr. Kapal Singh kept a good record of patients from 1970, and Dr. Zulaidin did the analysis. It's very clearly that since the UKM took over, we can see a drop in mortality. In 1981, it came to a level which is pretty acceptable for overall neonatal mortality, and it is around 10, but it's risen up slightly. So if we can maintain anything around 10 or 12, that'll be okay. And we've been able to do that all these years. And then the problem is that, are we really that good? Are we really that good? Okay. So we had to look at the operation for esophageal atresia. Because mortality for esophageal atresia is a standard gauge to gauge the quality of care in pediatric surgery. My boss, Mr. Ned Myers, when he read a lecture at the Royal College of Surgeons in 1974, in the anterior lecture, said that esophageal atresia is the epitome of modern surgery, which means that if you have success in it, it's like having crossed the sound barrier. Okay. Now, I'm proud to report that survival in the good and moderately risk group is more than 93%. In fact, the risk group A, under the old system classification, which includes what we call complications and heart disease, is about 100%. The C group is the highest risk, and mortality of 22%, rather acceptable. But when we convert it to the recent risk classification called the Spitz Montreal, Spitz is professor of pediatric surgery at Almond Street. He only classified into two groups. One, no risk from cardiac disease. Second group, severe cardiac disease. And our result is not good for number 2 yet. Right? The Great Ormond Street Hospital, which is the #1 children's hospital in the world, is that in 1980 they already had 97%, and in 2006 20% for the class 1, and for the class 2 59% and 82% in 2006, which means this is for them, the top children's hospital in the world. We'll come to that one day, inshallah. Okay. Now, team. One of the contributory factors to the good performance is teamwork. Complex pediatric surgery such as separation of conjoined twins, requires meticulous planning and organization. The anatomy of the baby has to be fully studied. We depend on a good radiologist. The two teams are selected, and the surgery is rehearsed. Okay? The anesthesia team need to be competent in simultaneously putting tubes into the throat of the baby because their faces are so close together. And intraoperative and postoperative care require real expertise from many disciplines, such as the radiologist, the neonatologist, the plastic surgery, the orthopedics, infectious diseases, hematologists, physiotherapists, technicians, nurses, and others as warranted by the situation. Okay. Now, in this slide, you're seeing only the operative teams, right? That separate the first surgery. But in subsequent surgery, we had to get the radiologist into the operating theater, and that radiologist is here today, Dr. Zaleha, where we had to separate the duodenum, and one baby had no bile ducts, the other baby had bile ducts. So we had to put some bile into the liver, and we didn't know where to put. And behold, we got Dr. Zaya, who came with the ultrasound. Here it is, and we put it there. So even the radiologist is required in the operating theater. Okay. So in this slide that you see is the what I call the first team. Somehow managed to get it from UKM in 2015. Now there are many others that I have not mentioned, but they provided crucial support to the comprehensive multidisciplinary. Now I'm going to talk about training and expansion of the services. Now, as head of the surgical services of the Ministry of Health, one of my primary responsibilities is to develop all the surgical specialties and subspecialties of surgery. In pediatric surgery, I took steps even to recruit expatriates from India and also train doctors, sending them off to start services in the other Ministry of Health hospital, as well as to staff UKM Trust and UMMC Medical Center and Hospital USM, as from this picture that you had. So from 1997, we'll be able to do that. Okay. Next, the postgraduate program. In 2006, Professor Ramanujan from University of Malaya matched me and said that, can we start a postgraduate program? So I supported that program, and then, so in 2006, program started by University of Malaya in collaboration with Ministry of Health, and later to involve also the UKM. I was chairman of the National Specialist Register in Pediatric Surgery, and I was also chairman of the conjoined board for pediatric surgery, and I also initiated the formation of the conjoined board, the first conjoined board for the whole country, and I was the first chairman also. Now, up to 2018, the program has successfully produced 38 pediatric surgeons serving all over the country in both public and private sectors. In 2014, UKM also started the pediatric surgery program. As I said now, is a joint program under the conjoined board. And I must congratulate UKM through their stellar effort by Professor Daya. It is now an accredited center for the examination of the European Board of Pediatric Surgery, and I'm one of the accredited examiners. Now, I would like to speak something of my another big interest, that is child and child family features in hospital, called child and family friendly features, right? I devoted a lot of my time in promoting child and family features in the Pediatric Institute. As you can see from the slide, I developed a model to showcase child and family friendly features to other hospitals. These features cater the needs of children and adolescents in their psychosocial aspects, being family-centered, involving many disciplines, having specially trained personnel, and safe physically and psychologically. So what are the features of a child-friendly hospital? These are some of the features, okay? Calm atmosphere, just now with the children, a school in the hospital, okay? A lot of playground, and mother, a separate bed for the mother, so then the child will never be without the mother. Next one. Now, together with like-minded individuals, we formed the Child-Friendly Healthcare Association and developed child-friendly standards to be used in hospitals. The association was launched in 2001 by Allahyarhamad Dato by the minister, and the patron was actually Dato, and the standards were handed over to the Minister of Health by the patron of the association. Next slide. And in 2003, Datin Sri Andon organized the visit at the Permaisuri Agung to launch the Parent Resource Center, which she built by getting some donation through KLCC, Surya KLCC. And then on that occasion, we had the two conjoined twins, you know, so visiting Professor met them. And then at the hospital, at the luncheon, you know, the Minister of Health, Dr. Chua Ju-mei, was asked a very pointed question by the patron, who was actually the wife of the Prime Minister. He had to answer. So this is what they said. With regards to your dream for a children's hospital, I would like to take the opportunity at this historic occasion to announce that we will be building a new children's hospital in the vicinity of Hospital Kuala Lumpur and intend to build others in suitable places, including Sabah and Sarawak. It is our aspiration that children's hospital will be at par and amongst the best in the world. Chua Ju-mei. Up to date, fortunately, we have now the Women and Children Hospital that's been constructed, and we have a Women and Children Hospital in Likas. It's a hospital that was bought over by the government and converted to a children's hospital to take away load from the Queen Elizabeth Hospital. Yeah. Now, going forward, where do we go from here? And as mentioned by the Vice Chancellor, children are the precious assets of the nation. Every child has potential which can be realized when given the opportunity. It is our duty to provide the opportunities so that talents can be nurtured and optimized. These opportunities must be given from young. One of them is in providing good neonatal care, such as in a dedicated hospital for children. We know that when neonatal care is good, especially premature babies, will have a higher chance of surviving. Better management of morbidity will help the children integrate into society, and the country's health indices, such as perinatal mortality and infant mortality under 5, we now use the under 5 mortality rates, will be very much improved. Now, most developed countries and many developing countries have children's hospitals. The UK Children's Hospital is, in my view, a historic milestone, but it is not enough. We need to improve more children. We need to develop more children's hospitals outside Kuala Lumpur, as was promised by the minister. With dedicated children's hospital, we should strengthen antenatal and fetal medicine. This is very important. I'm very happy that USIM has got somebody in fetal medicine, and we can be, a good center for it. We need to implement a better retrieval system, transporting the baby from outside, the sick children, and we need to have an increase in number of trained personnel. Research should be part of the hospital with publications and international collaboration. Right? Most importantly, I believe we should establish a systematic registry and institute a system of quality audit to ensure that quality is continuously enhanced. Okay? And we need it for the whole country to have an audit of all the pediatric centers so that we can monitor the quality and enhance the quality. Next slide. I think that is the end of my bit short talk on pediatric surgery. I tried not to be too technical about it. And I would like to acknowledge the following: my family, especially my wife, Dr. Syarahan, the children and grandchildren, of course, and all my colleagues in UKM, who are in UKM. They are in UCM also now, and who helped me out in the difficult years of 1976. You know, I was doing general surgery just like any of the two great guys that, you know, Professor Paediatric and Dato came, and I had to do, you know, all the colonic surgery and every surgery. On top of that, I had to do pediatric surgery. So I'm very grateful to them, you know, for taking away quite a bit of load from me. And the Vice Chancellor of UKM and the Dean of the Medical Faculty for some of the data and pictures that I archived from them. The Vice Chancellor of UCM, of course, you know, for his encouragement, and all the staff and colleagues, my departmental colleagues, for their input and support in preparing for this lecture. Of course, to the Ministry of Health, with the Director General, the Ministry of Health, the Director of Hospital of Kuala Lumpur for the statistics and the data of patients. And I will not forget N.K. Yong, who brought me into surgery, and Professor K. Sundram, who encouraged me to do pediatric surgery and taught me to fight the art of surgery, and numerous others. Thank you very much.
Thank you, my dear Professor Dr. Dato Mahmud. We appreciate if you could remain on stage. I would now like to re-invite Yang Berbahagia Professor Dr. Musa Ahmad to the stage to deliver our certificate of appreciation to Yang Berbahagia Professor Dr. Mahmud Mohd. He'll be accompanied by Yang Berbahagia Professor Dr. Muhammad Syamshir bin Ahmad Aris. Now I'd like to invite Yang Berbahagia Professor invite Yang Berbahagia Profesor Dr. Muhammad Syamshir bin Muhammad Aris to deliver a token of appreciation to Yang Berbahagia Profesor Dr. Musa Ahmad. Thanks. So as all good things, it must come to an end. We would like to thank you all for being part of this special day. Yang Berbahagia Professor Dr. Mahmud and VVIP are invited to view the exhibition at the rear entrance of the hall. But to remind you, there'll be a photography session. The first session will be Yang Berbahagia Dato with VVIPs. The second session will be with Dato with his families. The third session will be Yang Berbahagia Dato with pengurusan faculty. The fourth session will be Yang Berbahagia Dato with the advising committee. So there'll be a lot of features taken actually. There'll also be lunch afterwards anyway. So thank you so much for being here.